me share my screen. Today, we will cover two materials. The first is the spontaneous pharmacovigilance reporting system, and the second is the causality assessment of case reports of suspected adverse event. So before we go to this second topic, we have to pass this one first. But bear in mind that we have a lot of slides here. So for the first module, we have 51 slides. And for the second module, we have 63 slides. So we will have a break in between so that we can, you know, we can be, we can have a kind of refreshment and so on before starting the second module. So I need to state in the beginning of my lecture that if you find that my English is not so clear, please ask. Don't be shy, and I'm not felt offended because of that. So uh, just help me to help you understand this topic. Okay. Okay, let's start with the prayer first. So let's start with the prayer. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. May the Holy Triune God live and reign in our hearts and in the hearts of all people. Amen. May the darkness of sin and the night of unbelief vanish before the light of the Word and the Spirit of grace. May the heart of Jesus live in the hearts of all people. Amen. So, in the name of the Father, of the Son, of the Holy Spirit. Amen. So, in this module, we will look at the definition and scope of adverse drug reactions, and then we will compare the definition with the other definitions that are also used in the field of adverse drug reactions. And after that, we will look at some classifications of adverse drug reactions, or ADRs. And then the last one, we will look at the pharmacovigilance reporting system. So I plan to present a quick look. So I will not probably read one by one my slides, but please let me know if you are not you don't understand about some slides or some of our discussions. Okay, just open the microphone and then just speak up. Okay. Okay. So the WHO has a definition for adverse drug reaction published in 1992. An adverse drug reaction is a response to a medicine. So it is specifically to a medicine, reaction to a medicine, which is noxious and unintended, and which occurs at dose normally used in man. However, there are some definition, and this definition by WHO is quite ambiguous with the definition of side effects. And I think because of that, many people including pharmacists, uh, recognize adverse drug reactions as side effects. However, there are some definitions that try to differentiate between the side effect and adverse drug reactions. So we have the definition by Edwards and Aronson in 2000. It is an appreciably harmful or unpleasant reaction. So this adverse reaction is not a beneficial reaction at all, while the side effect may have, to some extent, can be a kind of beneficial effect. But for adverse reactions, Edwards and Aronson have a clear cut off that it is a harmful or unpleasant reaction, resulting from an intervention related to the use of a medicinal product. So a medicinal product here, it can be a drug from chemical medicine, can be also biopharmaceutical as well, which predicts hazard from future administration and warrants prevention or specific treatment or alteration of dosage regimen or withdrawal of the product. So this definition is longer than the definitions by the WHO, but it consists of more complete, uh, you know, complete uh, identification as well as the management and action after we uh, we can detect the adverse reactions. So I think uh, we, for me personally, I agree with these definitions of adverse reaction because it has a clear cut for with from it can differentiate the ADRs with the side effect. Okay, in drug safety terminology, Edwards and Aronson, and also Aronson and Werner, try to include the side effect and toxic effect as part of adverse drug reactions. However, the side effects that are included here is more likely to be the unwanted effect, the noxious effect only, not the side effect that can be beneficial. And then the adverse drug reactions may have can be used interchangeably with adverse effect. So we see the adverse drug reactions from the patient's point of view. So the reactions that occur in the patient, and for the adverse effect, we can see it through the product. So if we see it from the point of view of the product, we can say adverse effect, and from uh, the patient, we can call it adverse reactions or adverse drug reactions. So we have we already have side effect, toxic effect, adverse reaction, and adverse effect. I'm hoping that you are not confused by this term because we have more terms to come. And then there are adverse events. So adverse events is kind of adverse uh, reactions that are not to the medicines. They are not reactions to the medicines. We have adverse events here, and then inside the adverse events, there are adverse drug reactions. Yeah. So adverse event may be related to the medicines, may be related to medicines. And ADRs are not from errors. But there are also ITRs from medication errors. That can be from the procedural errors, the human errors, the product errors, also the utility errors and so on. And we have also medication errors that can cause harm that are not ATRs because of the procedure and so on that are not directly related to medical products. And there are also medication errors that don't cause adverse events. So there are different region of uh, adverse drug reactions and also adverse events and also medication errors. So if you read the publication in pharmacovigilance or pharmacoepidemiology and it is related to adverse reactions, then I'm hoping that you understand the difference between one to the others. So if we talk adverse events, we talk about the first, second, third, and fourth uh, pieces. And for our adverse drug reactions, we talk about the second and third pieces. So this is an adverse drug reactions is part of adverse event. So in the next module, we want to uh, usually in the beginning, we detect an adverse event first on the patients. We cannot directly conclude that it is an adverse reactions or adverse reaction on or an adverse effect. Okay, there are some methods that can be used to identify to make a conclusions, kind of causality conclusions to assess that is an adverse event an adverse reaction. So there are some methods to uh, make a clear causation, yeah, of causes and of an event to be an adverse reaction. Okay, so at the first we identify the adverse event first, and we can go uh, with several methods to assess whether it is adverse reaction or not. Because it is sometimes it seems that it is not really useful, but just like when we have this current COVID-19 pandemic in the beginning, in the early phase of the COVID pandemic, this method is very useful to understand because we tried so many uh, pharmaceuticals. We tried to use so many medicines we have uh, that do not have a particular approval to treat the COVID conditions. So we need to be aware of the adverse reactions. So yeah, and medication errors. Some medication errors can be part of adverse event, and some are not part of adverse event. So, and also we sometimes also heard about the drugs interactions, drug interactions. The interactions can be drug from a drug to another drug, and between one drug to another drug, and also can be between food and drug, between supplement and drug, between traditional medicine and drugs, and so on. So drug interactions is part of adverse drug reaction. So adverse drug reactions can be caused by one drug and can be caused by more than one drug. Okay, so you need to understand uh, these basic concepts of adverse drug reactions. And the study, part of actually the first study of pharmacovigilance, in my opinion, my understanding, uh, it is called as now it is called as pharmacovigilance. So pharmacovigilance is the science and activities relating to the detection, assessment, understanding, and prevention of adverse effects other or any other drug-related problems. So, uh, sorry, this I mentioned about DTP. DTP is drug therapy problems, and sometimes people call it as drug-related problems. So, in terms of terminology, we have a lot of terminology, and please bear with it. So, pharmacovigilance is the science and activities relating to adverse reactions, detection, and so on and so on. So, adverse reaction. Please be reminded that the adverse effects are similar to adverse reactions. Okay, but it is different from adverse event. Okay, and pharmacovigilance usually the data for pharmacovigilance can be generated from the fields. I mean, from the point of care, from health facilities, so on, and then usually it is reported to the National Pharmacovigilance Center. But uh, different countries may have different system in pharmacovigilance. Some of them may have sentinel centers that have a kind of cooperation with universities and so on. So they have the pharmacovigilance centers, not only not the kind of centralistic pharmacovigilance center, but can be also decentralistic. And they also we have globally we have WHO Uppsala Monitoring Center. So this is the global pharmacovigilance center that is existing there right now. So if you want to study pharmacovigilance, well, you need to go to the Uppsala. Uppsala is in Sweden, if I'm not mistaken. So we have the term also for adverse reactions, the actual and potential adverse reactions. So the difference between the actual adverse reactions and potential adverse reactions is that the actual adverse reaction uh, it is a reaction uh, that already appears in the patient. But for the potential ones, usually we can detect it from the screening of the prescription or the physician orders that could probably happen to the patients based on our prior knowledge of the drugs. And please be reminded that it can be in the form of uh, drug interactions. I mean, the interactions between drugs. Okay, so it can be potential. Or if uh, a patient has a kind of specific conditions or abnormal laboratory finding, and they have kind of medications that may not be suitable for his condition, his or her condition, then the adverse reactions might probably occur. Okay, and we have some classifications from adverse reactions. At least we have, uh, wait, at least we have three classifications. So we have the mnemonic system. Mnemonic system usually we use the alphabet A, B, C, D, E, F, but usually we just use the A and B. It is really the C, D, E, F are rarely used. So for the A and B, we usually this is the usually the long form of the for each alphabet. A is augmented, B bizarre, C chronic, D delayed, and so on. And it is very useful in for clinical purpose, and it is old-fashioned but most commonly used. So we have the type A. Type A is usually the dose-dependent reaction, while the B is not dose-dependent or independent to the dose. But we will see through after this slide. And the second classification system is the DOTS. DOTS stands for dose, time, and susceptibility. It is very useful for clinical purpose, and it is new. It is proposed by Aronson and Werner in 2003, and it is already used in big book of side effect, Mailer's side effect of drugs, because Mr. Aronson is actually the editor of the Mailer's, the book of the Mailer's side effect of drugs. So Aronson is the editor of that book, and this is comprehensive and could provide direction. So if somebody found adverse reactions, then in this dots category, in this dots classification system, they're not just divided to A or B, but they look at it more comprehensive, using the difference in dose and then the time of reactions, the appearance of reactions, and also the susceptibility. I mean the risk factors. So if you want to have a different terminology, the risk factors for a patients to have the adverse reactions. So the DOTS classification system is based on the reaction and also the drug. And the third classification is IDOS. IDOS is classified by Werner and Aronson in 2010, and it is not usually used for clinical purpose. So IDOS stands for extrinsic intrinsic distribution outcome and sequel. It is not for here. It is for industry purpose, and it is quite new. Yeah, I know. New here. It's already 20 years old, but yeah, we can say that it is still new. Okay. So we have three different classification system, yeah, for adverse reaction, the mnemonic, and it is the most commonly used, the dots and IDOS. Okay, only two that are used for the clinical purpose, the mnemonic and dots. Okay, and the mnemonic one, usually we just differentiate the type of reaction to the A and B, type A or B. So okay, For the mnemonic system, as mentioned, we have the A. Yeah, the A is the augmented. It is usually dose dependent and predictable from the non-pharmacology of the drug. For example, if somebody use a drug that can be used as uh, hypertension to an for example an anti-hypertension drug. So because can be dose dependent, the reaction of it can cause hypotension. Yeah, if the dose is more than the normal dose, but actually antihypertension like ACE inhibitor can give the first dose. It is known as first dose reaction. So usually the patients during when they are taking the first dose of ACE inhibitor will have kind of hypotension, but it's okay as long as it is not really uh, low. So it is predictable from the non-pharmacology, the pharmacological properties of the drug, and then common and low mortality. For the B type reactions, the bizarre, it is non-dose dependent. It is unpredictable and can lead to a high mortality. Just like for example, the Stephen Johnson syndrome, we can say that it is part of this. It is an example of the bizarre, bizarre, bizarre type of adverse reactions. But we have the C, D, E, and F. Yeah. So yeah, this is the example: the coxswain toxicity, serotonin syndrome, effect, and then the penicillin hypersensitivity, malignant hyperthermia. So something that usually hyper or it is mediated by immunological response can be classified as the B system. And if we go to if you jump to the management uh, of adverse drug reactions, if we have this bizarre reaction, we have to stop the the administration of the drug if it can be directly stopped. And then after that, we have to stabilize the patient's conditions. And after that, we can reintroduce, but to avoid the IV drugs, or uh, the, we change, we change, the subpharmacological class. I mean, or uh, if they have an alternative in the same pharmacological class, then we can may have a change if the pharmacological pathway are unknown, or we can still use the same drug, but we have to try at a lower uh, dose if there is no alternative to the other drugs. For the A reactions, we just to stabilize the patient conditions. Probably we have to stop the drug, but it is not mandatory as long as it may not cause to certain extent fatality. If it's not life-threatening, then it's usually okay. We just reduce the dose to patients. Okay, the dots. And this is the dots classification system. Uh, please be remember that we have please remember that we have in dots we see any adverse reactions from the dose relatedness point of view and the time relatedness point of view and the susceptibility point of view. So we have three different classes to see the adverse reactions. So from 3 dimension, okay, the dose for the dose resistance, there are some kind of there are 3 classifications. The first is the supratherapeutic doses, so it is a toxic dose. So if the the drug is given in a not in a normal dose, or it can be because of the dose that are given is normal, but the patients, for example, if they have low clearance, low creatinine clearance, then we have we probably give the normal dose as the toxic dose, because they cannot, you know, was just eliminate the metabolites from the drug. And the collateral effects that using the standard normal therapeutic dose, usually we call this as the side effect, and also hyper susceptibility reaction. If the dose that is given is very small, and the patient still have the reactions. And the second point of view is the time relatedness. The time relatedness is, uh, you know, it can be a time independent and it can be time dependent reaction. For the susceptibility, there are a lot of risk factors that can be uh, related to any adverse drug reactions, such as genetic, age, sex, physio alteration of physiology, for example, in pregnant women or people with certain conditions, and some exogenous factors, and also disease. So this is for the susceptibility point of view. There is genetic, for example, porphyria, and succinylcholine sensitivity, malignant hyperthermia, CYP isoenzyme polymorphism, and so on. And so let's go to the pharmacovigilance reporting system. Is there any questions to this stage? Is there any question? No? Okay, let's continue then. So I still have a lot of slides here. Okay, okay. Okay, for the pharmacovigilance reporting system, so like what I said before, pharmacovigilance is the science and activities. So it's not just the science, but also the activities of the detection and so on of adverse effects or adverse reactions. Yeah, adverse reactions. So uh, this, as you can see, like in the beginning of the pharmacoepidemiology modules, uh, the pharmacovigilance can be part of the fourth phase of clinical trials. After the drug is released, after a drug is released on the market, then we can do this pharmacovigilance. And pharmacovigilance depends on the reporting system, because the drug is already on the market. Then the only way to understand the new, the undetectable reactions from the previous clinical trials are from the practitioners. Okay. So this is uh, the scope is very broad. Yeah. So usually the core activity is the identification of previously unrecognized adverse events or adverse reactions with use of the drug. However, it is not sufficiently simply to note that use of drug can lead to an adverse effect or adverse drug reaction. So we usually, if we are not confident to conclude that the use of a drug can cause an adverse reaction, then usually we just put it in the basket of adverse events. Okay, events, because there are a lot of factors that may affect or may cause or may uh, contribute to the adverse reactions, such as drug dose response relationships, drug interaction, and so on. Uh, so there are some process in pharmacovigilance. So I took these materials from a book, Introduction to Pharmacovigilance. So you and I already put the title on canvas. So and this is just a summary of um, uh, a lot of readings in the book. So there are 5 steps. The first is signal detection. So you have to know in pharmacovigilance, you have to understand what is signal detection. The second one is evaluation and investigation. The third is taking action, and then communication and crisis management. We will go through the first to the fourth steps, not the crisis management. So what is signal? So signal most often arise from post-marketing surveillance case reports. Yeah, it is signal is collated and analyzed by drug safety experts, evaluated as clinical case areas, and considered for potential regulatory actions. So for sources of reports of adverse events, it's like what I said before, we usually do not directly recognize an adverse events as adverse drug reaction. So we uh, just recognize it as adverse event first. Yeah, adverse event first. So then we have to define. We will have some kind of methodology to uh, assess whether it is related to the use of medications or not. Okay. So the sources of reports can be from a consumer or health professional to drug manufacturer, from a consumer or health professional to health authority, using some programs such as MedWatch or Ultra Vigilance. This is MedWatch is in the US, if not mistaken, and Ultra Vigilance in Europe. And also case reports and case arrests with valuable clinical details. So this is again we jump back to the last 2 weeks modules about the case reports and case arrests. I'm hoping that you still remember. So case reports and case arrests, although they are in the on the base of on the base of the pyramid of evidence, so the low level evidence, although they have a low level evidence, but in terms of pharmacovigilance, in terms of adverse reactions, the science of adverse reactions, it is it is quite useful for the clinicians, because we don't need to have a lot of patients that have the similar adverse reactions to conclude that this reaction is caused by a particular drug. Yeah. because we want to protect the patients. We want uh, to ensure the patient safety. So the signal detection, the signal definition. So signal is a reported information on a possible causal relationship between an adverse event and a drug. Yeah. The relationship is being unknown or incompletely documented. So previously, so if it's already known, if it is known and previously also documented, it is not, it's no longer signal. Yeah. For example, we want to usually the signals are usually generated from the use of a new drugs that enter the market, or the use of old drugs that are already in the market, but used for but they are used for new conditions. Just like, for example, the basis for some drugs that are used, azithromycin, and also, for example, the chloroquine to for the treatment of COVID-19. Yeah, we can generate the signal in there. So usually signal requires more than a single report. Yeah. However, like what I said before, because in pharmacovigilance, our interest is to ensure the patient, to you know to help the patient safety, to help safeguard the patient safety. Then it depends on the seriousness of the event and also the quality of the information. If it is only a single report, only one report, but the which is the event is very serious, yeah, the severity is severe, and then the quality of the report is good, then one report, a single report is enough. So the data source may be associated with the previous unrecognized hazard. We are still talking about signal, so data source for signals may be associated with previously unrecognized hazard, and now probably can be associated with non-hazard. That may be different from the existing knowledge quantitatively or qualitatively. So this is you have the picture here. The uh, this is to uh, put an example, to give an example of the adverse reaction of thioprovanic acid. Thioprovanic acid, I think it is what is the analgesic or the painkiller, and cystitis. Cystitis is uh, an inflammatory reactions in uh, in urethra, or yeah, in urethra, in the urethra. So if someone use diapropanic acid infrequently, then it is okay. Then cystitis will not appear. But if somebody uh, use the diapropanic acid in the same in normal dose frequently, so the cystitis may appear again and again, and it may cause a serious effect, you know, because it can lead to the kind of the medical procedure to fix the inflammation in the urethra. So, but now the thiopropanic acid is no longer used. So, number of reports to generate signal is usually When the disease is rare, for example, aplastic anemia, toxic tuberculosis, then a very small number of cases can be used. But how many? It can be 3 cases. Yeah, can be as low as 3 cases. And in signal detection, we have to do a profiling to create the ADR profile or to find the disproportionality. What is it? Because we want to know whether this new adverse effect is a signal or not. Then we need to have a profile. So one method to do the profiling process is using, for example, in the UK, using the yellow card. So we have these numbers. Yeah, we have these numbers. This is they using the yellow card in mid 90s. There are more than more or less 600,000 suspected reactions in 30 years, in the last 30 years. So it is from 90s. And more or less 800 classified as UVTs. So it is about 0.13% in total. And rifabutin is correlated with some 41 cases of UTIs for a total of 55 reactions from rifabutin. So there are a total of 55 reactions due to rifabutin, and 41 of them are uveitis. Uveitis is like this. So the inflammatory of the uvea is here. So the redness of the uvea. So using this simple table, we can. Do you still remember the odds ratio and risk, relative risk? So it looks like this. So this is the proportional reporting ratio. Using this PRR, PRR, we can define whether uveitis from rifabutin is a signal or not. So we calculated the PRR, the proportional reporting ratio. The first proportion is the proportion of ADRs which are uveitis with rifabutin. So 41 divided by 55. So we have 0.75. And the second one is the professional ADRs with uveitis, uveitis from all other drugs. So 754 divided by 600,000. So we have this number, and then we divided the first proportion to the second proportion, and we have 556. So this proportional reporting ratio is quite high. Yeah, it's not quite that, but it's very high. Yeah, very high. And then the chi-square, we have the significant value here. So p less than 0.01, and we have the 22,000, the chi-square. So in this case, we are confident to say that the what is it, the rifabutin can cause uveitis. So if the please memorize this, the cutoff points for minimum signal is when we have PRR, the proportional reporting ratio, more than 3. Here we have 500s, right? 500s and 156. And then the second one is chi-square, should be more than 4. We previously have 22. Yeah. And the number of cases is more than 3, except for special cases. Yeah. So here another example. Uh, this is from the captropil and calf, the dry calf. Yeah. So between 1982 to almost 1984, there is just one report. So the PRR is only one for captoplan and calf. Yeah. So please be reminded that the number of PRR uh, involve the calculation of the total reactions from the calf from any other drugs before. Then there are uh, there were a lot of reports afterwards to 1987. So the number of the reports increased significantly. That's why we can say that there is a causation, causal relationship between captopril and CAP. Okay. Another method of disproportionality. So not all uh, nations, not all countries use the same method, just like what people in UK do. So they in the Netherlands, for example, they have reporting odds ratio. WHO using the ICO using the Bayesian methods. The USFDA using these Bayesian methods. The multi-item gamma Poisson shrinker. Okay, and then after we detect the adverse reactions, then we sorry the signals, then we do the 3H. Yeah, so this is to make which one is important, we which one we have to follow and so on. And after that, for the impact analysis, the regulator may use the evidence score and also the public health score. And if they found that it is good, yeah, they can classify it into 4 different levels. The high priority, need to gather more information, so they will continue the analysis by waiting for more data to come. Low priority and no action. And after the signal prioritization, the evaluation and investigation. Yeah. So I think this is just a procedural. So please, you can see, you can read by yourself. But I want to understand, to emphasis in this slide. There are frequency descriptors that are uh, internationally used for the frequency of adverse drug reactions. It is said to be common the if adverse reactions happens between this is for specific drug and specific adverse reactions happen in 1 in 10 to 10. So sorry, 1 in 10 reports. So if there are 10 reports and uh, more than one report uh, describing the same adverse reactions from the same drug, then we can say that it is very common. And then we have the very rare, it is less than 1 in 10,000. So this is very important. That's why I emphasize on this is like we have the report of the, the death or the fatality from the injection of uh, a vaccine, a COVID-19 vaccine in Europe, yeah, in early, I think it is in early 2021 or in by the end of 2020. So we have that report. Yeah. Then because the media follow the cases closely, then it, so many people feeling, you know, anxious about the situations or about this fatality. But if we uh, have a look at from the point of view of pharmacovigilance, then we can say that the fatality due to the blood clotting, if I'm not mistaken, if I'm not mistaken, from the vaccine is can be can be classified as a very rare reactions because we have a mass vaccination at that time. Yeah, so there are. I'm not discounting that any fatality is not important. So it is very important to be our concern. Okay, uh, but we have to probably it is more important for us to understand what kind of the profile of those who die probably be due to the vaccination rather than be afraid and do not want to have the vaccination because the benefits from vaccination outweigh the risks of being exposed to COVID-19 in the last for the previous variants that may cause uh, fatality. So because the benefits outweigh the risk, then I think, and also we can say that it is the reaction is very rare. Then yeah, I think it is okay. I mean to take to the vaccine. I remember that I told my friends who have elderly people with them to to stay on vaccination to uh, I asked them not to avoid the vaccination. Okay, and then yeah, the and potential options and so I think please what is it read the rest of these modules by yourself. Okay, is there any questions here? No? Is there any questions? If there is no questions, then I close these modules and uh, let's have a break for 5 minutes. So we will start at 12, a quarter past 12. Okay, we will go to the next module, which is the causality assessment. Okay, have a good break.